I make sure I get to hear about their accomplishments, and I acknowledge the ones that I'm genuinely impressed by, right, for it. Because I think with alcohol or with being black and blue at 2 p.m., at any walk of life can bring out a lot of shame and embarrassment, because how do you not talk about it? So I think it's good to be a little bit cautious around that. It's good to be curious about their strengths, their successes, all that kind of stuff. And you don't necessarily need them to have that aha moment and the insight that connects it all. I think for me, it's more about how do you give them enough information so they know that they can come back if they need to.
I think certainly me, I tend to support a certain population, and that population has some, I don't know, there's some consistency as to what those folks would be. They're people that have struggled with addiction for a number of years, and they've had a lot of consequences from it. That's more or less, or younger people sometimes quite young that are new to it. But this recently, where I work, I encountered an individual that was unique to folks I've supported before. So, and I just wanted to maybe get some of your insights about this person. So, a successful career lady who had, let's say she's in her 70s. She got to our emergency room because she had fallen in the bathroom, had a very bruised face. So there's been not a lot of medical complications here, but what was significant about this is it was 2:00 in the afternoon, and she was intoxicated. So they sent me to talk to her, and no one had ever talked to her about addiction in her entire life, and I just felt so wholly unprepared to, I just felt like I didn't have the tools to address what her journey forward would be like, right? Like what, where she's at, and maybe it's all the same. I don't know, but I didn't know if you had any kind of tidbits and kind of tools for tips to help me navigate conversations like that.
So with cases like this, especially the elderly thing, and how you felt around speaking to an elder, I get that same experience, and I'm not sure where it comes from. I have memories, when I was a resident, if I went had my geriatric rotation, so people, whatever, 65, 70, 80, I couldn't interrupt them. And some patients had some form of memory impairment. They would tell stories that took a very, very long time. And in psychiatry, you're supposed to do a tight 45-minute interview when you're being evaluated, and the stories would just go on and on and on. And in real life, I don't interrupt as much either. And typically what I do, especially if someone seems like they have a lot of pride, they've accomplished a lot, I make sure I get to hear about their accomplishments, and I acknowledge the ones that I'm genuinely impressed by, right, for it. Because I think with alcohol or with being black and blue at 2 p.m., at any walk of life can bring out a lot of shame and embarrassment, because how do you not talk about it? So I think it's good to be a little bit cautious around that. It's good to be curious about their strengths, their successes, all that kind of stuff. And you don't necessarily need them to have that aha moment and the insight that connects it all. I think for me, it's more about how do you give them enough information so they know that they can come back if they need to. And my mind, and part of it is that I've had so many people I've worked with where they'll have a month, 6 months, 9 months, whatever, of success, and then they disappear when the lapse or relapse happens, because there's such shame that comes with it as well, no matter how open I try to be around it. With people in their 70s, I always try to figure out what the drug does for them. Early on, sometimes there's a reward or anxiety or whatever. Sometimes eventually it's more the negative feelings that go away with it. I try to track the amounts, right? So is it a one-time thing? Is it a several-time thing? And how many are they going through in a day? If it's more than 10 standard drinks a day, I always think about the detoxification phase. I'm going to have to get this person off alcohol and make sure that the withdrawal symptoms are tolerable.
Right.
And then I think about the maintenance phase. And I do it through indirect curiosity, and I figure out what they know about it. And then I make sure before they leave, they know about the detoxification phase, the maintenance phase, the importance of skills. I have something in the back of my mind around screening for comorbid mental illness or memory deficits, which will usually come at a future visit if the person does show up. I talk about the vitamins like B12, thiamine, folate, all that stuff that's there. And the goal is actually the exact same as for the patients you're more likely to see. I actually want them to come back. That's it. I want that connection. I want them to have a good experience, and I want them to come back. And it's very, very tough to get people to come back. And when they're 70, they've had a fall, they have bruising on their face, they may not want to go to an addiction clinic, right? And so it may just be me sending a note to the family doctor. The family doctor knows those things.
Yeah. So right, so that's helpful, and especially always you want to be mindful of nothing you say is going to get hoping that nothing you say is going to get someone to go home and cold turkey it, as they say, of alcohol and
but you also want someone to drink forever, right? Like how many people have said, I can't stop because I've had a seizure. It's like 2 years later they haven't seen anybody, and they're still drinking the Mickey and a half a day, right? Like there's ways to coach on safe tapering too.
Right. Okay. Are there any particular things that medically that someone that's of that age is the withdrawal any different?
So, I mean, the one thing we always worry about is Wernicke's or Korsakov's, and we worry about these three main symptoms. One is the nystagmus. So there's that eye movement thing where they can sort of, but it's hard for the individual to tell it's there. Balance difficulties, and then memory or levels of consciousness difficulties as well. And if you have one of those three in any way during the withdrawal, you want to make sure you give them a lot of thiamine, preferably IM or IV at higher doses. And some people pick it up, some people don't in terms of clinicians. That's one thing that you worry about a lot. The other thing is that the withdrawal is not always predictable. And some of these patients, they may have longer trouble where they can't walk after the event. They may have a longer period where they're malnourished, so they don't have the diet and the stuff there. We regularly see people in hospital where the alcohol withdrawal is the only reason they're there, and they end up having to go to rehab after physical rehab for like a week, 2 weeks afterwards.
Right.
And normally it's like 3 to 7 days for alcohol withdrawal, so it can linger in that sense as well. I mean, those are the main things from my end. Sometimes when you do get falls, you do sometimes get brain bleeds. So a couple of colleagues of mine, they'll regularly do CT scans, and you'll be surprised how many find these old, small bleeds, from the past, because the person fell. I mean, it may not have been their first fall. It may have just been the first time they came to hospital for it. Yeah. And then also there's always that risk of that ongoing balance stuff. So just the ongoing, maybe it's gone to the point that it's going to stay with them for a bit.
Right. Now, I don't know if this is true or not, but the way I normally, if somebody is, let's say, has an otherwise what we would call a normal life, right, as far as days of the week and what they do and whatever, and I always considered that if someone is intoxicated or someone starts drinking at 2:00 in the afternoon, it's not, unless it's a liquid lunch, as they would say. This is usually they're drinking to a level where this is to help with the shakes and the withdrawal of the night before, right? Typically, often.
I mean, it could be. I mean, I put a lot of value on the narrative, right? And so, if they are saying, I get shakes and sweats, sort of here and there during the day, I have some balance difficulties, then maybe that's the case. Sometimes when people retire, they just don't have other things they're doing. They'll sometimes have a lunch or a late lunch, and then that's where the drinking will start in the social context as well. And so I've heard those stories as well for it too. It's hard to know for me, if it's daily drinking, more than 10 standard drinks or 8 standard drinks a day, then I start to worry more about the withdrawal piece. But if they have 5 days off in the middle of the week and it's just on the weekends, then not so.
The history seemed inconsistent. Because I knew that but when I saw her for the first time, it would have been like a minimum would have been about nearly 2 hours since the ambulance picked her up. So I knew she hadn't drank in that 2 hour period, and she was still slurring her words. So I would again, I don't know, because I would assume then she would have been probably more intoxicated a couple hours ago.
Oh, absolutely, yeah. And then I mean, sometimes that's where the blood alcohol level helps too, right? You get the blood alcohol level. They're there in hospitals, probably been a couple hours since they drink, and even if they're like talking to you like it's normal, but their blood alcohol levels through the roof, that's also a sign that maybe their tolerance is so high they're drinking more than you'd think they could be or should be.
Yeah, and my current role in an ED is kind of limited to it's not to get them to come back to the ED for care, but so what I ended up I had talked to her about her family doctor, and she has a good relationship as a younger woman that she goes to see, and she's comfortable with her, and so we ultimately agreed that would be something she would
that's a great idea.
Would talk to she would mention it to her, because she's never mentioned alcohol to anyone like that in her system of supports, and I mean that's all we were able to do, because she certainly wasn't going to be coming to. We're a long way away from getting her to an addiction clinic, getting her to any of those services, right? She wasn't going to a detox. I mean, we just weren't there yet, right? There was, I mean, it's hard to describe how accomplished this woman appeared to me, at least, right? Or how successful, and how much she seemed like a fish out of water to the system that I work in.
Yeah, and I think I don't know the right way to say this. I'm not convinced that people that are well off get good substance use care, right? I'm not convinced they get good care for their alcohol. I'm not convinced they get care for their withdrawal. I'm not good care for their anxiety. And in fact, if you have a place you can go for treatment, you can just say, hey, I'll see you this week, stay for 30 days, $30K, $100K, whatever it might be. And so even these programs that are charging money, I'm not always convinced they're offering the best possible care. And so it doesn't matter, I think, whether you're, homeless and you're on disability or social assistance, or if you're a CEO with all these funds, I'm not convinced you're getting good substance use healthcare.
Yeah, we'll put a link into our video up here now about a video we did on Matthew Perry, right? And our thoughts on how good a care he is. I don't know how many millions of dollars he spent on addiction care, but it was a lot.
Poor guy.
And both him as the patient didn't think he got good value, and us as the armchair quarterbacks kind of agreed with that too.
It's always hard being an armchair quarterback. You're not there. That's not an arena that you're in. And you try to have some curiosity and stuff. And for this person that you describe as seeing, I really think it's just giving them an awareness of what are some of those supports and stuff that can help.
Yeah,
and we should go over, because I can't remember. I think there's little handouts and guides for the family doc. So a handout that the family doc they'll just walk them through what those steps are. And there's ones for the elderly as well in Ontario. There's the Center for Effective Practice, right? And they have an alcohol guide that's very simple, concise.
Well, isn't
very
that
good for a family doctor.
The SPERT? Is that not the SPERT?
So the SPERT is the screening and brief intervention referral to treatment. It's not necessarily the physician sort of approach.
Okay.
It's done sort of administered by sort of ASAM, and it is an approach that you can take. I don't really do it often, and partially because I'm not really doing a screening. I'm just doing a full assessment,
right. And if they come to you, they've generally someone else has determined it, and so if they've owned, they have some sort of substance use concern.
Yeah.
Right. But at a family doctor level, it was something we used to recommend. Did we not recommend family doctors to do that as a brief screening still, or?
Yeah, they might be. I mean, I believe the data is mixed, but what do I know? I
thought that was the one thing the data was good on, is that these brief interventions are a good thing. Like doing the screening is a good thing to.
Yeah, no, I think the screening is a good thing. The expert's a very structured approach.
Yeah,
and it is recommended, but. Yeah, I don't know why
you're just negative about that. You're just negative about everything today.
Well, no, I think there's a lot of different screening tools you could use, and
do you have another one you want to recommend and plug here?
No, I just I think if alcohol is a concern, I like the Center for Effective Practice. They have this nice document for family doctors
Okay.
that would be helpful.
Can we put a link up for that?
Yeah, we can put a link for that. You
Okay.
know, I think it's a good starting point for the alcohol piece. Yeah,
right.
and I think you did a fantastic job with this person, because you sat with them, you spoke with them, and they left knowing there's options to reduce the alcohol if they choose to, and you gave information to a healthcare provider that they see regularly and trust that can help them.
Yeah, I liked how you said that you don't like. I wonder if a little bit of what you said, where you don't like interrupting. As I interrupt you, you don't like interrupting your elders when you're starting to do some of those early rotations, and I have to wonder if my own prejudice in the wrong way, or what, I don't know what it's called, when you just have you draw certain assumptions about people, and you wonder if you didn't give the right advice, right? Well, why is she not able to go to detox? She could have gone to detox. Why didn't I send her to detox?
No, I mean, I saw someone the other week who went to detox and they were scared shitless the whole time. Like, they're like, what is this place? Like, they didn't feel safe. There were people using drugs around there. People were screaming, yelling, and you could tell they're from a different walk of life.
And that's what was in my head.
It's not. They didn't look like someone that would be employed at a hospital or a Starbucks or like you know what I mean? Like, they didn't. And I know you can't judge a book by its cover, but like, the person was a young, athletic person, and they did not feel safe, right?
Yeah.
Can you imagine what a 70-year-old woman would feel who's frail, maybe had trouble walking after a fall?
And sending her into there, it would be like sending
environment. I think about the clinic that I used to work in, where there was another colleague that used to see child psychiatry patients right there, and then I think about people who are injecting and passing out in the bathroom versus like a 80-year-old woman with chronic pain, and I think we'll eventually have to figure out how to match treatment location to the person, so they can get that. We don't want a place the person will never come back to.
Right. No, exactly.
Right.
We don't want to
want a place
them,
where they'll never come back to,
and not trust us again.
Yeah.
Right. Or not trust anything we say because we sent them there.
Yeah.
I mean, that's what's going through my head.
You have to remember, like, just like with the naloxone, right? So there's a whole push to get everybody naloxone, right? And like, I was annoyed by that. Like, no, assess and treat the opiate use disorder. Why are you just giving naloxone? Because when you give somebody a checklist item, like, oh, I've done my job and it's done. And now we know that 70% of the overdose deaths were people that used alone, right? And maybe it wasn't different before naloxone. Maybe it's gotten better since then. But that was my gut feeling. Most patients I worked with would always use alone.
Yeah.
Right. And how are they going to correct their own overdose with their naloxone kit? Right. And so I think like we want to offer what works. We have to be very careful, right? Because if we hit that next tick box, we're going to be like, okay, good. We did it. We've cured and saved it. And then we have to wait for the data to come saying that, hey, you know what? It was insufficient what we did.
All right. Okay, well that's very helpful. I got some takeaway tips for supporting different folks than what we normally do, and the elderly specifically. So that's very helpful. Thank you.
I mean, I wouldn't mind just adding one extra thing. In Canada, they do have guidelines for the elderly for substance use disorders, alcohol, and other drugs. Okay. A colleague of mine and a friend of mine, he actually introduced me to my wife. He's one of the people on the team that helped to put them together, and so we include that link as well.
Is this different than the guidelines that we just spoke of a few months ago? The guidelines for the one drink a week thing?
No. This is a different one.
Different specifically for elderly.
Yeah, for elderly, this is more like substance use care, health, addiction medicine, healthcare for people that are older than a certain age.
Okay, and can we assume generally those limits are a little lower than they were for somebody who's 30?
No, it's what do you do clinically with them?
Oh, what do you do? Okay.
Yeah, what do you do? Like, do you do expert? Do you do a screening tool? Do you offer them a medication?
Okay, great. All right. Yeah,
it's like a guide for docs. It's not like a guide for patients.
Okay, perfect. Yeah. No, that's so we can leave that reference there too. Okay, no, that's good.
Yeah, we're done.
All right, good stuff.
Thanks for watching. If you like what you saw, please feel free to like and subscribe. That way you'll get notified when we come out with new content. We try to come out with new content about every week or so. So anyway, thanks again and see you soon.